Have more than 100. Go ahead. Assalamu alaikum, everyone, and I would like to welcome you to our master class of pancreatobiliary and HCC malignancy. It is a two-day chaired by me and Dr. Kannan Alshammari as a director for that meeting. And it will be a first day all about HCC, as you see here. And day two, we'll be talking about pancreatobiliary neuroendocrine tumor, and we end up by several cases. We would like to thank our sponsor, Lilly, Epson, Bayer, Pfizer, and AstraZeneca. And we would like to thank the scientific committee, all our attendees, sponsor, and organizing committee. So without any further delay, I would like to introduce our moderator for session one, Dr. Faisal Abel Khail. He's a consultant hepatology and transplant on King Faisal Specialist Hospital. And Dr. Fuad Sabatin is our medical oncologist in King Abdulaziz Medical City. Faisal and Fuad, the floor is yours.
Thank you very much, Dr. Ashwaq. First of all, I would like to thank the organizing committee as well as the scientific committee for doing this outstanding program for the hepatobiliary and pancreatic malignancies. And also, I would like to thank the sponsors for arranging it, Al Faisal University. And also, special thank to Dr. Ashwaq Al Olayan for her enthusiastic and organizing this event with her co-chair. And I would like to welcome also all the attendees to this session. And I will start by introducing our first speaker. Our first speaker is a colleague of mine, a friend of mine, Dr. Ali bin Mousa. Dr. Ali is a transplant hepatologist who is actually have a special interest in HCC, and he had his training in hepatology in Toronto University, and then he was focused on HCC management in the military hospital, and then he moved recently. Now he is in the liver transplant department in King Faisal Specialty Hospital and Research Center. Dr. Ali will give us an update about the epidemiology of HCC and in the Kingdom of Saudi Arabia, and what is the current data and registry of HCC. Dr. Ali, تفضل. Dr. Ali?
He is joining now.
Assalamu alaikum.
Wa alaikum assalam.
Thank you, Dr. Faisal and Dr. Ashwaq and the other members of the organizing committee for this important initiative. I would love to have more of that in the future, inshallah, from different centers interested in this important topic. And thank you also for giving me this topic, which is always dry and a bit boring, but inshallah, we give some information of interest to all the audience. So epidemiology of HCC is always a puzzle because of the problem in the reporting, in the way of diagnosing HCC, the difference in view between oncologists and sometimes the hepatologist in how to define a definite case of hepatocellular carcinoma. First slide is talking about very, simple facts about hepatocellular carcinoma, but they are really very important in impacting the outcome and the prognosis of the disease. It is a malignant primary liver tumor. It originates from the hepatocyte, not unlike the cholangio and the others where they originate from, cholangiocyte and the other cells. It But it is the most common primary liver tumor. Different studies reporting 80 to 90% of primary liver tumor to be HCCs. The thing is that the HCC is a killing disease. We might see that it is number 7 or 10 in the top, malignancies, but it is always the second in killing, unfortunately, patient. It's very high mortality is not only because we are dealing with a difficult disease, it is because it happens with a liver disease. And whenever we're talking about any treatment modality or so, we have to balance this. Some of the treatments are really effective, but unfortunately they impact the liver disease badly, and the mortality is because of the decompensation and not because of the HCC itself. It happens more in older population and those with more severe liver disease, and thus the treatment is becoming more challenging because now we have to treat a sicker patient. I know that, for example, breast cancer, colon cancer, and so are much more prevalent, but we don't deal with these sick patients. They are really patients with coagulopathy, with impaired synthetic function, encephalopathy, and many other, sequelae of liver disease, which makes the management very, very challenging. The therapeutic window is very short, and we have seen that during the COVID pandemic. Once some of our patients missed their appointment because of the lockdown or missed their procedure, unfortunately, a good number of them went into more advanced disease, and they turned from curative or semi-curative into palliative patients. It needs expertise in management, specialized treatment center. What is the challenge here is that referral is also taking time. If a patient is from the north part of the kingdom where there are no expertise in dealing with this disease, radiologist, oncologist, or hepatologist, or transplant center, then referring these patients, the transportation, and so might really affect the outcome of the disease. Now, why the incidence is high for the HCC? Because of highly prevalent risk factors. We have higher prevalent liver diseases, viral hepatitis. Until recently, it used to be the top of the etiological factor for chronic liver disease, and that's hepatocellular carcinoma. And now we're talking about NAFLD as really coming very quick, with a much higher incidence, maybe because we are diagnosing more of these cases, but also because of higher incidence of diabetes, obesity among population. Alcoholic liver disease, certain part of the world, autoimmune liver disease, inherited liver disease. Some of my colleagues in pediatric hepatology, they're talking that some of these inherited diseases are really the highest incidence in the world happening in the kingdom. And this is well known. Why? Because we like to have the family marriage and more consanguinity, leading to concentration of some of the mutations in certain families, to the extent to that if we hear a patient name or the family name, we know what is the diagnosis. It's up to that limit. Environmental risk factor also, aflatoxin, Africa, alcohol in Europe, and to a lesser extent the smoking. We don't want to talk about numbers here because this is not the aim of the study, of the presentation. Now let's look at the geographical distribution of risk factors. We expect that alcohol is more prevalent in Europe and America, and you can see that there 30% or so, up to 50% in certain parts of the world. The etiological factor for liver disease is alcohol, leading to cirrhosis and the development of hepatocellular carcinoma. While hepatitis B, no doubt, Asia top the countries in the incidence of hepatitis B, and hepatitis C in Africa and also in Europe. The HCC is the 7th most common cancer in the world. Now we're talking about the global incidence of HCC. It's number 7. However, as we said, it is number 2 as a killing cancer. The global incidence is 9.3 per 100,000 population, but the mortality is 8.5. So almost the similar number of the patients who are diagnosed. There are patients dying from the disease in each year. The cumulative incidence of liver cancer from birth to age of 75 estimated to 1.6. That's in general population. Obviously, in a patient with risk factor like a viral hepatitis or an inherited liver disease, this will be much, much, much higher than this number. The gender difference is very clear. We know that HCC is a disease of men. The ratio is at best 2:1, where the other part of the world, like Europe, the ratio is 4:1. For each 4 men, there is 1 woman having HCC. Age is directly related to the incidence till age of 75, then it doesn't really show much of difference. However, the median age at the diagnosis varies between countries, again, according to the risk factor. So in the state, we're talking about 60 to 65, while in Africa and Asia, the incidence, the age of incidence is lower than that. Now, GloboCan is a very important resource for all of us, oncologists, hepatologists, to know the epidemiology of disease globally. And you can see the difference in colors. Why? Again, because of the difference in the risk factor. We're talking about Asia, East Asia, where hepatitis B is more prevalent, more incidence of HCC, while, for example, in Africa, where we have the hepatitis C and the other environmental risk factor like aflatoxin, leading to higher incidence of HCC in that part of the world. We'll talk about Saudi Arabia at the end of the presentation, but you can see the difference or the variation of the incidence. Now, this is very important question to answer. I don't know if we can answer this. Definitely, it needs a lot of research in this subject, but what is the impact of the intervention? We know that we're all excited about the achievement in treatment of viral hepatitis. Now, everybody with hepatitis C is almost 99% cured with the excellent antiviral agent. Hepatitis B is almost always controlled, not yet cured, but it is well controlled with very potent antiviral agent. Did this impact the incidence of hepatocellular carcinoma worldwide or not? You can see that the mortality of the HCC, which what matters really, is, with the exception of the countries down here, which are the Asian countries, where we see there is downtrend and lower mortality related to HCC, and that is because of less incidence of HCC. You can see that the countries in the middle, United Kingdom, USA, the trend is slightly up, still more in men than in women. And in some other countries, the trend is still plateauing, not showing clear down or up trend. So with all this intervention, we can see that the incidence hasn't really significantly declined, and probably it has increased in some parts of the world. Now, talking about each risk factor alone, hepatitis B, we know the correlation between hepatitis B, viral load, and the incidence of HCC. The higher the viral load, more HCC happening. Now, what if we reverse this? Now, we decrease the viral load by the treatment. What happens with that? Now, prevention is better than treatment. Now, if you prevent hepatitis B with the vaccination program, that is an excellent, vaccination. With us is now for 30 years, so we cannot study patient older than that age, between 25 to 30 years of age. It definitely reduced. The white bar reflects those who were unvaccinated, still high incidence of HCC. The black bars are the ones who are vaccinated, so it's definitely less, but it's not zero. It's still in the age group between 20 to 25 years, the cumulative incidence rate is about 0.55, which is still not that low, indicating that other risk factors are really important. The genetic part, the exposure part, the HP core part are really playing a part in the incidence of HCC. Now, if you because an older drug, and although it is less potent, yet it showed reduction in the incidence of HCC. But if we talk about the medication that we are using now, which is the entecavir and tenofovir and TAF lately, the incidence of HCC at 5 years have reduced from 13.7% to 3.7%. It's almost 80% reduction, but it's not zero, unfortunately. So we have to still follow this patient. We have to tell them that you are at risk of HCC, and we expect that some of them will still develop hepatocellular carcinoma despite the excellent control of their virus. This is another important study from Toronto Center showing that if you talk about the absolute number of HCCs, no doubt it is rising. Although the incidence of end-stage liver disease is declining, and if you do the age standardized rate, it's less, but still the HCC on rise liver incidence of cirrhosis and end-stage liver disease are less. Very complex. Why is that? Maybe because now we are treating the population, and those who are having are younger age group. They have, less severe disease, but they will live longer, and their risk of at the later age will still be significant for hepatocellular carcinoma. Why? Because we know the virus incorporates into the cells, and there is no way still we get rid of the cyclic DNA. Hepatitis C, again, good control of the virus with the DAs. What happens is that definitely there will be a reduction in the incidence of HCC, but look at the red line. These are patient, let's say the red line, no cirrhosis. I'm sorry, I cannot see the lines nowadays. No. So no cirrhosis with no SVR, still you can see it in the middle, and no cirrhosis with SVR. It's almost back to general population incidence of HCC. And if there is cirrhosis with no SVR, look at the green line. It's really the probability of being free from HCC is very low. And that is what's happening now, that we are seeing now a lot of these patients who cleared actually their virus, but they are cirrhotic. And each year we see HCC happening in a certain number of these patients. So yes, we cured hepatitis C, but we did not prevent HCC in all this population. Sorry. Alcohol, without delay, we don't see much of patients with alcoholic liver disease, but in Europe, obviously they are seeing that. And if the patient is drinking more than 3 drinks per day, heavy drink, then the chance of developing hepatocellular carcinoma increased by 2.5 folds. Now, coming to Saudi Arabia, where we are, the estimated age standardized incidence rate that number compared to other parts of the world. Let's compare ourselves to our neighbors. Kuwait is 5, Qatar is 5, Oman is 4.4. We are almost similar, while Egypt is 34. And I don't know if this is really the actual number or it has changed with the control of hepatitis C, but obviously the higher hepatitis C incidence is probably the part which caused the higher incidence of HCC. UK 5.3. USA is still higher than us, and Turkey is 5.3. Now, these data came from us, obviously, from our registries, from our studies. So do they reflect reality? Is this number true or not? Is the top 10, but the number of patients diagnosed in 2015 is 376. Probably our colleagues, hepatologists, will agree with me. This number maybe reflects 3 centers or 4 centers only. The number is much higher than that, and it's again reporting diagnosis. I don't know if the registry is still considering patient with HCC if they have a biopsy or not, but before it used to be Now 90 or let's say 95% of patients with hepatocellular cell carcinoma are diagnosed radiologically, and we don't biopsy these patients. Do I have time? How many minutes more? Still 8 minutes. Yeah, so 376, and that is 3% of all the liver, of all the cancers. Probably does not reflect the real number in the kingdom, and that is because we do see, for example, King Faisal, we receive around 1,000 to 1,500 referrals a year for liver transplantation, and we're at least 25% of these patients are HCCs. So just to have an idea, I mean, it's almost 500 or so of HCCs being referred for liver transplantation. And this is what I call it a referral bias, because the center who believes that patient presenting with advanced HCC and he's not candidate for transplant, they will not refer. So there are still a number of HCCs that are not referred to us just because they are not meeting the transplant criteria. Now, if we look at the incidence by gender, in males, it is number 6. It is not on the top 10 for females, fortunately. And we know it is, although it happens in ladies, but it is more prevalent in men. Let's go over some of the reports from the kingdom. They're very important to us. The first one was King Faisal experience, not because I am from there, but because this is having the highest number of patients and was, on long duration of time. So they collected the cases between 1975 to 2014, that is almost 40 years, 2,800 of primary liver cancer. They found that hepatocellular carcinoma constitutes 80% of them, cholangiocarcinoma 11%, hepatoblastoma is 4 increase in the incidence of hepatocellular carcinoma or the primary liver cancer from 60 cases at 2004 to 80 cases in 2014. Obviously, this is before the era of the directly acting antiviral agent. We don't have yet data on this from, I think, all the centers, and we're looking for some of these data to see. Male to female ratio, as mentioned before, 2 to 1, but the highest incidence by age was 6th, 7th decade of life. We're quite similar to USA. Majority of patients were diagnosed at localized stage, 44%. Again, we'll stop at this point. Why is that? We believe that actually smaller number come with this stage, the early stage, than 44%. But because of the definition, like oncologists, maybe they were using the TNM system. So if the tumor is localized to the liver, no metastasis outside, no lymph node involvement, probably that will be considered an early disease, but hepatologists used a different system, which is the Barcelona clinic system, which incorporate not only the stage of the tumor, but also the stage of the liver disease. And therefore, we will see in the coming studies what is the percentage, which I believe that it is the real percentage of early HCCs. And another very strange finding, which we need to really dig into this, why the risk factor of viral hepatitis was only 28% of this group of patients, which is definitely very low compared to other studies from us and from other parts of the world. And the most common treatment for liver cancer was resection, followed by transplant. Almost, let's say, 30% of the patient were, let's say, candidate for curative treatment. So treatment for hepatocellular carcinoma probably will be discussed later. It's either curative, semi-curative, or palliative. And curative means that you aim to have a patient without, a disease or a disease-free, and it's usually resection, liver transplantation, or radiofrequency ablation in some selected patient. The rate of transplantation is 9.5, probably because the study is a bit old, and now more patients are being transplanted for HCC, and this rate should be higher than this number. Now, Dr. Al-Swat reported this data from the Saudi registry. Maybe some of you know that there is something called SOLID registry, which we hope that it will be a real, a countrywide registry. Unfortunately, now the contributing center are not a lot. I mean, it's not collecting data from all the centers of the kingdom, but it is rich in data. So they look at these 363 patients between 2003 and 2008, and median age as before 66. 73, like 3:1 male to female ratio. But here the hepatitis B and hepatitis C was the risk factor in about 48, that's almost 75% of them are having hepatitis C. And this was what we were seeing before, eradication of viral hepatitis lately. Now, the stage of the disease, 53 had CLIP score of 4 to 6, which means advanced disease. And 55% had large multinodular tumor, and 16% had vascular invading surface. So actually, majority of these patients, when they came, were either advanced or intermediate stage, and small number of them came with early stage. And most of the patients had decompensation at the time of presentation, the 44%. That's another 50% of these patients, although they have small tumor, but with this definition of, the personal clinic definition, they are not considered an early stage disease. The mortality was very high, 85 or 84% of patients died during the study period, which is really just, we're repeating what we said at the beginning. It's a very killing disease, and unfortunately, despite all the treatment modality, mortality remains still very high. The data from Jeddah, 128 patients, HCC between 2008 and 2014, reported again hepatitis B and C to be the main risk factor in about 60% of the patient. But they defined that, or they mentioned that 60% of patients had cirrhosis at the diagnosis. Question mark about this number. Why? Because we know that at least 90% of patients, when they present with HCC, they have at least cirrhosis or advanced fibrosis. The problem here with this number is probably because of the modality of diagnosing liver cirrhosis, because at that time we did not have FibroScan, most of the centers. So the definition was based either on a biopsy or presence of viruses with cirrhosis on the image. And we know that some patients really, they are cirrhotic and yet they don't manifest this manifestation, this finding at the beginning of the disease.
Dr. Ali, your time is up.
Can you try and wrap up, please?
Dr.
Sorry?
Ali, your time is up now. So if you can conclude, please.
Yeah, conclude in 1 minute. So this study from South region, 118 patients, and they reported hepatitis B, hazard risk is about 34%, which means that if somebody having hepatitis B, his risk of developing HCC is 34 times than the general population, compared to hepatitis C, which is 11. A finding which needs to be also looked at carefully because does not really meet the others. Now, this experience from National Guard, which will be the last one, total of 235 patients included, viral hepatitis 75%. This is real. Personal clinic stage A, which is the early stage, is only 30 or 33%. And this is actually what we are seeing always in our clinic, that majority of patients, they don't come in the early stage, while 70% of the patients will come into either intermediate or late stage. And the median survival was 15 months. This last slide is from also King Faisal experience, that what are the indications for liver transplantation? Is it the same like before? No, the difference is that between 2001, 2010, HCV was the main indication, 42%, hepatitis B, 21%. Now, alcohol or non-alcoholic steatohepatitis is 30%, which is the highest indication for liver transplantation. And that is clearly shown in this slide. This is, expecting the incidence of hepatocellular carcinoma in Saudi Arabia in the future, and based on together with NASH and NASH-related end-stage liver disease. So the blue line is the incidence decompensated cirrhosis secondary to NASH, clearly rising until 2030. Mortality related to that disease will be clearly rising, and HCC will be rising. So we don't really expect a decline in overall incidence of hepatocellular carcinoma for at least 10 years from now in the kingdom. Thank you so much. And sorry for being late, Dr. Faisal. Questions at the end.
Thank you, Dr. Ali. Thank you. I'm so glad to be part of this important meeting, and I would like to thank the organizers and the directors of this course and my co-chair, Dr. Faisal. And it's my pleasure to introduce Dr. Mohammed Al-Arabi, who's our next speaker. He's well known as a consultant intervention radiologist, and he's going to talk to us about curative treatment of HCC by the interventional radiology team.